सो हेलो ब्यूटीफुल पीपल, स्वागत है आपका आज के इस नए वाले व्लॉग में। तो आज है हमारा थेरेपी का कॉन्फ्रेंस, तो इसलिए हमें जाना है अभी थर्ड कॉर्पस। हमने कॉन्फ्रेंस के लिए तैयारी की है और मेरे जो ग्रुपमेट्स हैं हम सबका भी हर एक का एक एक टॉपिक था जिस पे हमने प्रेजेंटेशन बनाया है, तैयारी की है, टॉपिक के बारे में पढ़ा है। वहाँ पे क्वेश्चन आंसर सेशन भी होगा टीचर्स के साथ। तो ओवरऑल अच्छा कॉन्फ्रेंस होने वाला है, ऐसा मुझे फील हो रहा है अंदर से, क्योंकि हमने तैयारी भी अच्छी खासी कर ली है। तो लास्ट टाइम जो आपने अगर लास्ट वाला ब्लॉग देखा होगा तो वो था थेरेपी के ओलंपियाड के बारे में। तो आज के इस ब्लॉग की शुरुआत करते हैं और चलते हैं अभी थर्ड कॉर्पस, जो कि है पार्क को भी प्रोस्पेक्ट 7 एड्रेस पे, और देखते हैं कि ये कॉन्फ्रेंस कैसा जाता है।
At least I know the scientific research world is big and we have a big timing for the explanation, but to make a time control, we should try to finish the presentation in 6 minutes. Okay, so we can have some time for questions. Don't try to extend more than 7 to 10 minutes because it will take a lot of time to complete everything because 13 presentations are there, so act accordingly. Okay, so let's open the conference. First report, I have life-threatening ventricular excess systole by Sohan Lal Chowkari Nina Ram, 5th course, and Khan Anna, 5th course. My name is Swavi Sonlal Nenara. I'm from 5th year and I'm going to present the topic on ventricular extrasystole, and my co-author is Khan Anam, also from 5th year, and our scientific advisor is Associate Professor Microphenova Irina Sergeyevna ma'am. First, we'll talk about a little bit about ventricular excess systole in general. What is a ventricular excess systole? It is also known as a premature ventricular contraction, which is the premature depolarization of ventricular originating from an ectopic foci. It can be in various places like below the bundle of hairs or in around the ventricles. Why does ventricle fire early? There are two, we can classify it in two types: cardiac causes or non-cardiac causes. In cardiac causes, the majority is ischemic heart disease or prior myocardial infarction. Then we can also see in heart failure or cardiomyopathy like dilated cardiomyopathy, hypertrophic cardiomyopathy, and then in valvular heart disease, hypoxia or myocarditis. Student Captain Ursa in front of you, and I'll be telling you the study about the obesity and symptom severity in osteoarthritis, which will be a gender-based analysis of the high-risk population. And my co-authors are Punita Karthik Kasturinder and Sohanlal Chaudhary. Let me first introduce you to osteoarthritis, what osteoarthritis is. So it is basically a wear and tear disease, and this disease progressives. It is a progressive type of disease which progresses with the time, and it is most prevalent joint disorder worldwide, which impacts the knees, hips, and the spine. Why particularly these joints? Because they are weight-bearing joints in the daily life activities. These joints help us in movement and physical activities. So this condition shows a significant gender disparity. Although it affects the both sex, it is more common in women. And obesity is one of the primary factors which affects the osteoarthritis. Along with these, other factors like metabolic disorders can also affect. Hypothermia can also affect. In women, like wearing high heels can also cause osteoarthritis. And there are stress on the weight-bearing joints like knees, but also contributes to the low-grade systemic inflammation that can accelerate cartilage breakdown. So here in this picture you can see this is normal joint how it is existing. And in the second you can see there is a slightly progressively thinning of the cartilage which is present between the two joints, two bones, and then it causes synovitis and the progressively thinning of the cartilage, which further causes osteoarthritis, and it leads to pain. So let me tell you about the pathophysiology of the osteoarthritis, how it is caused, and it is basically a complex interplay of the mechanical, biochemical, and metabolic disorders, and this is characterized by progressive breakdown. So it progresses with the time; it does not have any sudden onset, and it progresses how the time progresses. The disease also progresses and causes severe pain. there is a cartilage breakdown, articular cartilage, subchondral bone remodeling, and sinual inflammation. All of which contributes to the pain, stiffness, and functional impairment. So here in this diagram you can see we have a knee joint, femur and tibial joint. So what happens here is there is a formation of the fibroblast and osteophyte formation, which leads further to the chondrocyte activation, which leads to the increase in the MMPs and aggregatinase, which are the enzymes which leads to further ECM breakdowns, leading to the destruction of the cartilage and forming the osteoarthritis in the patient. So with the background of this, as we know what osteoarthritis is, what is the pathology of the osteoarthritis, let me tell you why we conducted this study. So aim was to investigate the association between obese and non-obese, both males and females, with the late stages of the knee osteoarthritis, which is third and fourth grade of osteoarthritis. So, what the material methods we use for osteoarthritis were, we use analysis of the 80 patients which were collected from the Orenburg Regional Clinical Hospital, which had knee osteoarthritis of the grade 3 and grade 4, which is already progressed osteoarthritis. And this patient came for knee joint replacement. And we collected the information of the patient, anamnesis, we calculated the BMIs, and we use such scales like WOMAC, VAS, and PUS. Now, why particularly we use this scale? Because WOMAC helps in assessing the pain, stiffness, and also the functionality. VAS helps in measuring of the pain, what severity of the pain the patient has, and also PUS. So PUS is a method which provides us more larger evaluation of the quality of the life and also the functioning of the patient and how severe the pain can occur in the patient. Now, according to the data we collected, we got some results. The results were of the 80 patients of the total, 66 were females and 14 were males, of which the average age was 65.5 years. And grade 4 osteoarthritis patients were 22 and grade 3 were 58. Now here we can see that grade 3 osteoarthritis was more prominent in the most of the patients. So because of collective information that 58 patients, including males and females, had a grade 3 type of osteoarthritis. Then we subdivided them into the non-obese and obese, males and female both. So we found that 52% of the total population were non-obese males, and 47% of the total population were non-obese females. Then similarly in males we found that 7% of the males were obese, whereas 93% of the females were found to be obese, so they had more prominent features of the osteoarthritis. Then we had, on this we got some clinical outcomes. We found that the males had higher WOMAC in the non-obese, also lower VAS and variable PUS scores. Females had higher VAS in the non-obese, higher PUS scores, obese and versus non-obese. So after this we did a theoretical statistical trend analysis where the p-value should be more than 0.05 for all. So we didn't got actually the practical value because we had a small group of population. If we extend the area, then we can get a larger group of population and variables can be varied. So even if we didn't got the statistically significant data, the data which we got was clinically relevant, and we found that the non-obese males have higher WOMAC and VAS and PUS strength. So here you can see the non-obese males had 117.625 the non-obese males, 6 VAS score in the non-obese male, and PUS strength was 37.4875 in the non-obese males. Whereas in the obese male, we can see that significantly the symptoms, daily activity, sports life, and the quality, these symptoms were higher in the obese males, which proves that the obese males had more problems in their knee joints. So similarly, we carried out this same statistical information for the females and found that the obese females had higher WOMAC and foods life quality. So with the time progresses, the osteoarthritis progresses, and this causes more worse symptoms in the females. And non-obese females, we found that the higher fast food, sports life, daily quality activity, and pain symptoms were higher in the non-obese females. So hereby saying this, I would like to conclude that this study affirms that the disease was significantly found in the females and it was predominant in the females. Also had strong association with the more pronounced symptoms, and it showed that they are worse symptoms overall and reduced life quality. While the male contributed a smaller subset, but non-obese males demonstrated a trend. So according to the trend, the data which we got, the results which we got were clinically relevant, and as compared to the obese counterparts, suggesting there were different symptomatic profiles. So for avoiding such things, there are many precautions which can be done, like in the daily life, like having healthy food, not eating junk food, weight loss, and and also other diseases like endocrine diseases can lead to osteoarthritis. So this can be prevented.
How do you think what your scientific research, how it control in future for your practice?
So this data will help us to analyze what are the reasons for the obesity progression of the obesity in the females as well as in the males. So according to this, we can plan a treatment for these people, and in treatment also we can give yes. And if the disease progresses to a lot, like severity, like 3rd and 4th grade, then the treatments like acetaminophen can be given to the patient. Also, for lubrication, hyaluronic acid can be introduced in the joints. IV corticosteroids can be given. So we can get a proper information according to which we can plan the treatment for the grade of the osteoarthritis to the patient. So according to grade, we can treat the patient. Next.
And attention folks, I hope the podium doesn't break due to the statistical data of epidemiological crisis in India prevailing over last 5 years. So I would like to take over the podium. So before jumping into the epidemiology, I would like to give a short and sweet note about tuberculosis. Tuberculosis is a contagious infection caused by Mycobacterium tuberculosis. It is a gram-positive bacteria. It is problematic just due to the structure of the bacteria. It has a lipid layer covering it, such that it makes very problematic even for the diagnosis. We have to use special stains like acid-fast stains to analyze the presence of Mycobacterium tuberculosis, and also it is very critical for the antibiotics to act over it too. On this introduction, I would like to tell about some progress made in India. So it is most important to talk about the marked progress India has made over last 5 years. That is, there is increased number of incidents notification and increased number of screenings, and also there is increased progress in the treatment plans we got. So the main reason behind this is the large-scale public campaigns done by the government, and also the technological screening support provided by the government institutions in India. But still, we face a persistent challenge in eliminating the tuberculosis in India. As we all know, our Indian government has planned to eliminate the tuberculosis by the 2025. But still, we are facing the struggle to eliminate it, mainly due to 2 reasons. At first, it's due to our lack of consciousness over the drugs. So it led to the case called drug-resistant tuberculosis. And second, as we all know, there is presence of malnutrition still in India. So our first main problem, the drug-resistant TB. India remains the global leader in drug-resistant tuberculosis. It is being the bottleneck for eradicating or eliminating the tuberculosis by 2025, which has not been done. And all over the world, globally, India tracks about 32% in the drug-resistant tuberculosis, and also rifampicin-resistant tuberculosis. So there is a decline in the TB prevalence in India. India has significantly dropped in TB cases, but still incidents have been increasing because of the increased screening programs and the rising in case notification. And also there is lower mortality rates due to the treatment programs done by the government, and also the Diksha Yojan program. And also there is a treatment such as present, which, as I told already, it crossed the global average from 88% to 90%. Alone as a highly populated country, this is very tremendous achievement for the India. and closing gaps. That is, the number of undiagnosed and unreported cases have reduced totally from millions to fewer thousands in 2024. This is due to the triad I have shown there, and also there is presence of nutritional support. Next, please. As a conclusion, I would like to conclude that Indian government is doing all the steps. It's our share. We have to travel along with the government such that this will be done as a community, and also there is increased amount of tuberculosis. So prevention measures must be advertised to everyone who doesn't have knowledge about the tuberculosis. Thank you.
I am Surin Patra, 5th year student of Orenburg State Medical University. Today my topic for discussion is the impact of the obesity on clinical and laboratory parameters in patients with rheumatoid arthritis. In relevance, I need to talk about what is what. What is the wide adipocyte tissues described as an endocrine organ which secretes a wide variety of hormones known as the adipokines. And what is adipokines? These are the pleiotropic molecules that contribute to the so-called low-grade inflammatory state in the obese subjects, creating a cluster of the metabolic syndromes including an autoimmune and inflammatory diseases that affect the joints and the bones. Now it is a schematic presentation and the relation between the adipokines and the rheumatoid arthritis. We have 4 categories here: the leptin, the adipolectin, the vistin and the destin. If we look into the first point, the leptin, the level is increased or even static. It induces the regulatory T cells energy and the T cell receptor, causing a hyper-responsiveness. And this, the anti-TNF alpha treatment doesn't even differ or alter the level of the leptin levels. Matrix metabolite 3 in the chondrocytes. If we talk about the visfatin, the level increases, which induces the interleukin 6, interleukin 8, and the MMPs in the synovial fibroblast. Lastly, the restin, the level increases, which induces the tissue necrotic factor alpha and interleukin 6 in the sinusoids. The purpose of this study was to identify the characteristics of the clinical manifestation, disease activity, laboratory and radiographic changes in the patients with rheumatoid arthritis and obesity.
Grazie Ulrike, dragă enthusiast and this to present this. Mnie da Munita Karthikeyan Kasturi Rangan and Jatha Buddha. Today I will demonstrate a presentation about single nucleotide polymorphism effect on osteoarthritis. My scientific advisor is Krishna Kushna. Special thanks to the ma'am because she gave me opportunity to conduct the research and present the presentation in front of you guys. What is SNP? SNP is nothing but a single nucleotide polymorphism in which a total gene is not changed, a particular nucleotide is changed between the different genes. Like you can see a same person, like 3 different persons with same genotypes, but only one nucleotide is changed. Thousands of different nucleotides when changed, we get a proximity of what kind of genetical disorders are arising or any kind of drug responses or any kind of tracking inheritance. The aim to investigate association between specific genetical polymorphism like FGFR, TGFA and GDF5. Kind of WOMAC score. WOMAC score is a type of score in which we understand the stiffness, joint mobility, the pain and how the patient feels. The higher the score, the higher the pain, the lesser the mobility. But for the KOOS, it is reversed. Lesser the pain, better the mobility. In patient with CC genotype, I have trained the high KOOS pain. What is TGF? A transformation growth factor alpha is located on the 13th chromosome on position number second chromosome on position number 13.3. It is acting as a ligand for epidermal growth factor. Epidermal growth factor acts on different things like cell proliferation, angiogenesis, joint repair, and all. It is a potent mitogen. It acts for the regeneration in the joint. Then we have GDF5, growth differentiation factor number 5. It is located on 20th chromosome on 11.2nd position, encodes for secret ligand TGF beta, and it helps in the skeleton development, joint formation, tendon motility, like tendon maintenance. It regulates cartilage, bones, teeth, and everything. Same significance data, and we obtained A genotype was 30.26%, GH genotype was more than 50%, and G genotype was 30.26%. Patient with A genotypes are comparatively more older than others and has a higher KOOS symptoms and higher BMI. And what we observed in G genotype was a high osteoarthritis with much less aggressive format. Carotid artery atherosclerosis in perimenopausal women. My scientific advisor is Lilia Zensova ma'am. We have introduction. Cardiovascular risk is comparatively biggest problem of mortality worldwide, and because of heart attack and strokes that predisposes to the atherosclerosis of carotid artery. Introduction. Perimenopausal woman is comparatively now considered as a particular risk for cardiovascular diseases because of estrogen is decreased and eventually having a metabolic and vascular changes. Now we consider risk of coronary heart disease in a woman is significantly twice in the perimenopausal years. 80 females in which the 40 females were perimenopausal with an average age group of 47 years and postmenopausal 40 females with an age group of 52 years median. What we understood in the premenopausal and postmenopausal women, total cholesterol was 4.69 in the premenopausal, while in the postmenopausal 5.33, and in low density lipoprotein was 3.06 in the premenopausal, while in postmenopausal 3.55. And atherogenic index was 1.29 and 1.36 comparatively in the pre and postmenopausal, and we obtained P significance very low, means the research is very low. How we examine the particular common carotid artery? We put the USG probe and we measure for the intima thickness. If it is more than 0.8, we consider it as a development of the particular thickening of the carotid artery. What we conclude, we found out after menopause the cardiovascular risk significantly increases. We saw the lipid profiles were more problematic in the postmenopausal women, like very low density lipoprotein, LDL, atherogenic index, and the carotid artery thickening was compared to the premenopausal. So we can conclude like effective on more therapeutical measures when the patient goes into the perimenopausal age from 45 to 58 for better result and reducing the thromboembolical ischemic infarct in the brain or any kind of emboli or ischemic infarct, reducing the cerebral impact. And moment of gratitude. I want to thank Lilia Zensova ma'am of microbiology department. I can't even think of research without her. It all started in 2023. And special thanks to Lilia Zensova ma'am and continuing right this right now in front of you. We have 9th report, prevalence of antibiotic resistant strains in India. I would like to call Hanika Deepak from second year.
Myself, Sanika Deepak Deshmukh, and I study in second year. My co-author is Punita Kasturi Rampat, and my scientific associate and my current scientific teacher is Lilia. So, in today's presentation, I will be discussing about prevalence of antibiotic resistant strains in India. In 2024, WHO released a list of priority pathogens. In these, they divided the pathogens into 3 priorities, which were the critical priority, high priority, and medium priority. Critical priority includes the pathogens which were threat to the society and were highly resistant. In high priority includes the pathogens which were difficult to treat, and in medium priority includes the pathogens which still require monitoring. And the list of pathogens are included in this slide. So my aim of the topic was to analyze the data on the prevalence of antibiotic resistant clinically significant pathogens in India. After this, I got a result that 688 publications were released in the last 5 years, and out of which 165 publications were alone in the last year, which significantly states that the increase in these interest in this research area, and it also stated that the 73 publications have been free full text, means it was open for all of us. Now I would like to talk about some pathogens which were highly resistant. First is E. coli. E. coli predominantly showed phylogroup B2 followed by B. Most prevalent resistance genes were CHUA-A, FIM-H, CRAT, and KPS-MT2. FIM-H, CHUA-A, and HLY-D were significantly resistant associated to glycouria, bacteria, and gene. And it was also observed that HLY-D methicillin resistant Staphylococcus aureus. is significant public health concerns and it is found in healthcare purpose act as a reservoir scheme. In Indian Association of Medical Microbiologists observed the colonies of the Staphylococcus aureus in the nasal mucosa of hospital medical personnel, and it were highly resistant towards the multi-drug resistant strain. And it also the most common was the SCC make type BE, followed by SCC make 4, SCC make type 1 to 3. So in the conclusion, I divided the pathogens into gram-negative bacteria and here are the gram-positive bacteria. As we see, the gram-negative bacteria was most resistant towards the antibiotics. And E. coli was resistant towards the ampicillin, pneumonia was resistant towards the cytoflaxin, Acinetobacter species was resistant towards the ciprofloxacin, ceftazidime, and insulin. In gram-positive bacteria, S. aureus and Enterococcus species was both resistant towards the enteromycin and ciprofloxacin. In the conclusion was made that the farming practices, inadequate treatment, farming frameworks, and the high burden of infections were the main reasons behind the increasing antibiotic resistance in India. It was also observed that the cephalosporin showed the highest resistivity, that is of 84%, and Carbapenem pictus has a higher risk of death, that is was 32%. Thank you.
I'm very happy because these young students have interesting scientific reports. All reports what we listen were the best. I don't talk another because some students prepare more information about more theoretical microbiology part. Secondary part of our conference is internal disease and information about most important diseases what present in our world same. And for that, I hope then you have new knowledge, you will have new idea, and for next year I will see any another students near the report, near the jury, and I think that some of these students will write not only the student scientific articles and more, and from any students we will see any Nobel Prize man or woman in future. Our moderator of our conference, I want to talk about our Punita Katuringan. This is the most students what have first positions in the Orenburg region by foreign students, and they participate in the Moscow students. And anyone talking from these 13 reports, half of this, it's my students with who I'm working from secondary course before for some time for 6 course yet. And for that I hope you will be the best doctors, and we will listen your name in the different articles, different magazines. Thank you very much.
Dr. Sonal Dinara, 5th course, and Karna, 5th course, life-threatening ventilator exercise.
दोनों सर्टिफिकेट
Free. Окей, значит, Саника, Зипа.
And I hope it will start only your scientific working.
Second grade. Если даст.
Вообще today, you all students have the best report and the best knowledge have who come they participate.
सो गाइज वी आर फाइनली डन विद द कॉन्फ्रेंस. या ये कॉन्फ्रेंस था एक्चुअली इंटरनल डिसीज़ का. इंटरनल डिसीज़ और उसके आसपास के सारे रिलेटेड डिसीज़ का जो भी अपना अपना सबका एक एक टॉपिक था. उसमें मेरा टॉपिक था ऑस्टियोआर्थराइटिस का, ओबेसिटी रिलेटेड का, ट्यूबरकुलोसिस. एंड ही रियली डिलीवर्ड वेल. लाइक मुझे सबसे बेस्ट जो भी प्रेजेंटेशन था दैट वाज ऑफ योर्स. या फॉर श्योर
I won.
नहीं, मैं तो भली जीत नहीं पाया, मतलब ना ही फर्स्ट सेकंड थर्ड रैंक कुछ नहीं था. बट माय फ्रेंड्स वोन एंड दैट इज़ आल्सो बिग थिंग. एंड या कोई बात नहीं, ये एक कॉन्फ्रेंस है, ऐसा और कॉन्फ्रेंस आते जाते रहेंगे, आगे भी ऐसा होता रहेगा कुछ ना कुछ. तो ऐसे आगे वीडियोस भी आते रहेंगे कॉन्फ्रेंसेस के. और मैं भी कोशिश करूँगा कि अगले किसी और कॉन्फ्रेंस में थोड़ा सा और अच्छा परफॉर्म करूँ, ताकि मे भी प्राइज़ मिल जाए, मे भी क्या बोलते हैं रैंक आ जाए, कुछ तो हो जाए. लेकिन या यू डिलीवर्ड इट सो गुड. और बाकी मेरे दोस्त अभी आ रहे हैं और थोड़ा सा बाहर भी हम यहाँ पे फ़ोटोशूट करेंगे. अभी ये जो थर्ड कॉर्पस है हमारा, एक्चुअली फिफ्थ नहीं थर्ड कॉर्पस है. इसकी बिल्डिंग सबसे बड़ी बिल्डिंग है हमारे जितने भी सारे कॉर्पस है उसमें. तो यहाँ पे अभी थोड़ा सा फ़ोटोशूट करेंगे बाहर. और थंबनेल के लिए भी यहीं पे थोड़ा सा वीडियो बोल रहा हूँ, फ़ोटो ले लेता हूँ ताकि अच्छा सा थंबनेल बन सके इसका. एंड या दैट वाज इट फॉर टुडेज़ व्लॉग. मैं मिलता हूँ आपसे अगले व्लॉग में. तब तक के लिए अपना ध्यान रखो, अपने फैमिली का ध्यान रखो, सबका ध्यान रखो. और तुमचे रजा की तुम्हें